How are we going to diagnose it? How are you going to diagnose it? CSF, mildly elevated protein, gamma globulin is increased, and most importantly, oligoclonal bands. What's oligo mean? Little. So here I want you to think of your clonal bands, or the bands in general, and as you're interpreting a band, you'll have these little bands called oligoclonal bands, and those are quite indicative of multiple sclerosis if found by investigating your cerebrospinal fluid. Visual evoked potentials. Remember, you do have vision issues. Useful in demonstrating evidence of prior optic neuritis, but keep in mind though, frequently the visual evoked potentials are found and there's no history of the visual loss. Just keep that in mind as well. So you could have such abnormalities taking place, but there is no history of optic neuritis. So these are things that you want to put everything together. Obviously, they're not just going to give you one fact and expect you to know what's going on. They'll give you multiple clues, and then you have to make sure that you use your clinical judgment to come to the proper diagnosis. What about treatment as such? If it's acute relapse, you're thinking about high-dose IV corticosteroids. And then you have disease-modifying agents. And these include your beta interferons, beta interferons, beta interferons. I repeat that multiple times here because you don't want to confuse this with alpha interferons or gamma interferons. These are beta. Then you have something called gatrimer acetate, and you have one of the monoclonal antibodies. Nadazulumab is something that you want to keep in mind. In the parentheses here are the trade names, but more importantly, you want to know about the generic names, obviously. In refractory cases, you're not really left with much of an option except to start using chemotherapeutic drugs, in other words, immunosuppressants, and that, of course, has its own host of adverse effects. At this point, I'd really like for you to focus on acute relapses and the disease-modifying agents, such as your monoclonal antibodies and the beta interferons. You also have, as I said, the glatiramer type of acetate. To summarize, in multiple sclerosis, risk factors: Caucasian, female population, the genetic predisposition I told you about, family history, may increase 15-fold risks. Preventive medicine, really, we don't know of any. Really difficult, unless there's a family history already. Signs and symptoms, we've talked about this quite a bit. We talked about the blurred vision, the optic neuritis. We talked about internuclear ophthalmoplegia, the conjugate gaze type of issue, and then also median longitudinal fasciculus. In addition to that, there might be ataxia, numbness, remember, CNS type of issues. Differential diagnoses include infections, maybe vasculitides, and I showed you an imaging study where I showed you this plaques around your ventricles. Ventricles. And what do those plaques represent, please? Good. White matter degeneration. And we talked about the treatment. What kind of interferon? Beta interferon and glatiramer acetate. And if it's an acute type of relapse, then you're thinking about high-dose IV corticosteroids. So once we've done, you've noticed now over and over again in neuropathology that I have these topics and these pages in which I've summarized the pinpoint information or details that you want to take out of each one of these diseases. These are important. Now the variants, just very quickly, I don't want to spend too much time here. Rarely, if ever asked, but just to make sure that you're clear, you can have neuromyelitis. It's called Ordevick's disease. It's bilateral optic neuritis. Very rare, but variants nonetheless, just to make sure that we're clear. Rapid progressive. Then you have acute. This is called Marburg form, in which this is a young individual, maybe even lesser or younger than 20. Fulminant course during the period of several months. What does that mean? Remember, it usually takes years and decades and decades and decades for this to usual, most common clinical course. My goodness, this is rapidly acting, months. Large and numerous plaques, widespread destruction of myelin. It's the variants that are extremely difficult in terms of to arrive at a diagnosis quickly, but nonetheless they exist for multiple sclerosis.